So in this series of lectures, we're going to look at the respiratory system from the perspective of pathology. So we're going to look at the kind of assessment and treatment of different respiratory disorders, and then I'm going to run through kind of the most common clinical respiratory disorders that we see, kind of what we need to think about in terms of potential workup, referrals, and the overview of the treatments. So we're going to start first with kind of an overview of respiratory pathology, then we'll look at the assessment in this video, and then in the next video I'll look at treatment and some of the common medications used for respiratory disorders, and then we'll get into the individual conditions. So as mentioned previously in the respiratory physiology lectures, talked about how we can think about the respiratory tract really as having two different types of zones, and that would be the upper respiratory tract, and that would be your nose and the sinuses, the pharynx, really all the way down to the trachea. And then from the trachea downward, we have the so-called lower respiratory tract. And why that's important is that different pathologies seem to affect each. So if we look at upper respiratory tract disorders, they're primarily related to infectious agents, and the majority of them are acute situations, although some can become chronic, so like chronic sinusitis and pharyngitis. But when we think about most of the upper respiratory tract, colds and those kinds of things, that's all more of an acute issue. Versus with the lower respiratory tract, we can have acute issues like bronchitis, and bronchiolitis, pneumonia, respiratory distress syndrome, but many of our chronic respiratory illnesses of the lower respiratory tract are associated with some sort of chronic inflammation, fibrosis, not related to infection, and that would be asthma, chronic obstructive pulmonary disease, which includes chronic bronchitis and emphysema, bronchiectasis, and cystic fibrosis, which I'm not going to talk, I mentioned that a little bit. This is a genetic disorder, and again, it affects the chloride transporters, and it creates very thick mucus in the respiratory tract. It affects the ability of the pancreas to put out proper pancreatic enzymes, get thick mucus in the GI tract. And so patients with cystic fibrosis are a lot more susceptible to lower respiratory tract infections like pneumonia. And then there are what are called interstitial or restrictive lung diseases, and these are associated, a lot of them, with chronic inhalation of coal dust, asbestos, silica dust, things like that. So a lot of these are occupational injuries or related to air pollution, and that would be asbestosis, silicosis, hypersensitivity pneumonitis, call it farmer's lung. So those would be the more restrictive diseases, not involving so much the airways like the obstructive diseases do, but more the actual lung tissue in the alveoli. Autoimmune lung disease also would be in this category. So lupus, one manifestation of lupus is pulmonary disease. And then lung cancers, and so we'll go through the different types of lung cancers. A couple other little respiratory disorders would be pleural diseases. So we talked already a bit about pleural effusion and pneumothorax and the pleural mesothelioma, the cancer. One area we'll come back to in the cardiovascular block is to talk about pulmonary vascular disease, and that would be things like pulmonary embolism, pulmonary arterial hypertension. That's usually a result of heart failure, left heart failure, the blood backs up in the pulmonary tree, pulmonary edema and hemorrhage and so forth. So we're not going to discuss that in these sections, but we're going to kind of go through the bulk of the rest of these and kind of touch on them a bit in terms of what their clinical presentations are, how we assess them, and what the kind of current treatments are around them. So from the perspective of traditional medicines like Chinese medicine, the lungs are said to be affected, as we could imagine in our current thinking, by external and internal factors. Now, we always talk about how in our modern language we talk about viruses and bacteria. In the traditional languages, we use the terms such as wind cold and wind heat, these kinds of things. So the idea that environmental factors actually play into that. It's a bit of a contentious issue in the modern biomedical sense, and there's actually an institute in Britain that's done studies on this where they expose healthy patients to cold and wind and damp and all this, and they find there is no increased susceptibility in those patients. In fact, some of them ended up having stronger immune responses than people that weren't exposed to that. So in our current thinking, we, of course, think in terms of pathogens as external factors, viruses and bacteria, fungi, etc. But, if we kind of look at the so-called wind-cold conditions, they typically correlate with what currently we're talking about viral infections versus wind-heat. Not always as clear because influenza falls into this. Influenza, we get fever, we get redness, all of that, and that's a virus. But typically more with bacterial bronchitis and pneumonia. We start to see a lot more pus, we see a lot more cytokines, fever responses, that sort of thing. So we might think of wind-cold as more when your innate immune responses only are engaged, versus wind-heat is when your adaptive immunity is engaged as well. Remember, adaptive immunity is involving T and B cells. They're going to start creating antibodies. You're going to get the acute systemic responses like fever and so forth, and that's going to be more a hallmark of what we call heat in those traditional ways of thinking. So that's the external invasion, and that's going to be more applicable, of course, to the acute lung disorders. With the internal factors, we see that involved in the chronic lung disorders. But that said, we spend a lot of time today talking about pathogens. And what we really always keep forgetting is really we need to also talk about the internal factors that keep your immune system strong. And that's really what we should be focusing on, in addition to all the other microbe fear-mongering that's going on, is to look at how do we keep our appropriate innate and adaptive immune system strong. And that really depends on the function of your internal organs. So we can have issues. Stomach heat rising would be, for example, the acid reflux picture we talked about in GERD. Actually, that's from another block, sorry, but if we think about acid reflux, if we think about that often causes a cough, that can cause injury to the lungs, that would be what we might call an excess factor. Liver spleen disharmony, this is more like dyspepsia, maybe issues with bile flow and so forth. And then deficiency factors, qi and yang deficiency of the lungs, which based on the physiology lecture I just gave on the lungs, you might say that relates to thyroid metabolism to some degree, is lung qi. So we can look at hypothyroid disorders related there. Pancreatic insufficiency. Again, in Chinese medicine, when we say spleen, we often are talking about the biomedical pancreas and its activity in terms of digestive enzymes and so forth. And then kidney, with the adrenals, we know that DHEA, an adrenal hormone, is extremely important for lung immunity, for upregulating Th1 type cytokine responses, which basically is what fights your viruses and everything else. So that's if the DHEA level goes down, your cortisol levels go up. Happens with chronic stressors or just with aging, that you're going to be more susceptible to these infections. But also that would also be the case with these chronic lung diseases like asthma and so forth. We're going to see those hormone dysregulations. And then yin deficiency, lung, but especially kidney, we might think of that as low estrogen, more of a menopausal kind of state. So these are some internal factors that we always want to think about when treating respiratory disorders, especially chronically, but even acutely. And I find a lot of people address, pharyngitis and sinusitis acutely and whatnot with all sorts of different heat-clearing herbs or warming herbs or whatnot. But really what we need to think about is, what are the underlying endocrine system and everything doing? And is that leading to a healthy immune response? So we can think of the lung yang, really, again, as the metabolism of the lungs, the arterial blood flow, the metabolic activity. So when that lung yang is deficient, then we can have an invasion, a wind-cold invasion of the lungs, maybe damp, phlegm obstructing, and that would be your typical upper respiratory tract infection, URI or URTI. And then more on the excess side, we can have the wind-heat invasion, and those are typically URIs with more heat symptoms. Typically, they're viral, but again, in some instances, we can have bacterial. Influenza might be in that category as well. In the Chinese medicine thinking, we of course have herbal formulas, some that are warming, like this guizhi tang cinnamon decoction, and then the yin chao sun, more heat clearing, that's Lonicera and Forsythia. These are very important herbs. In the Western herbal traditions, we use things like elderflower and so forth as more of a heat-clearing herb for influenza. And that's, I think, an important category. A lot of people treat, the common cold with, elderflower and echinacea and things like this. Those are technically actually heat-clearing type remedies, and they would not be applicable to the typical cold with low fever, with feeling cold, with sort of clear mucus and that sort of thing. So that's the lung yang disorders. Lung qi would be problems of the autonomic nervous system, and we're going to see that more typically with maybe asthma and those kind of conditions, any chronic lung disease where we maybe have bronchoconstriction and so forth going on. We might think of an opposite pattern of lung qi constriction. That would actually be more of a sympathetic dominance pattern. That would be with a lot of anxiety and so forth. And so that typically sympathetic excess would open your airways, but paradoxically people sometimes become desensitized to the sympathetics over time. So that's why I put a question mark if that's a real pattern here. And then lung yin would be more of dryness. So deficiency would be dryness, low-grade fever from that dryness. We call that deficiency heat. Might say that's a low surfactant, low immune paint and mucus picture, maybe related to low estrogens. And then a lung yin excess would be more the phlegm pattern. So these are, again, kind of pattern-based thinking, but we can find actual neuroendocrine correlates with each of these, and I think that's important if you're not in Chinese medicine, if you can think about it from that perspective as well. So when someone presents with a respiratory disorder to the clinic, it's always important to have a biomedical working diagnosis. Now that's going to be not really going to be the case for, a simple upper respiratory tract infection or so forth, but more serious chronic lung disease like asthma, COPD and whatnot can be life-threatening, and so that's going to need a more thorough workup as well as a staging in terms of how severe that illness is. And as we get through asthma and so forth, I'll talk about different staging systems that we have. We, of course, always try to differentiate an upper versus a lower respiratory tract disorder, whether it's acute or chronic. Again, acute generally can mean anything under 3 months, but usually in this case for like respiratory disorders, it's 2 weeks. So acute would be 2 weeks. From 2 weeks to 3 months, we call that kind of subacute. And then after 3 months, we're into the chronic zone. Are there any red flags that need potential urgent referral? And so I'm not going to talk much about the upper respiratory red flags because there aren't as many. I'll just mention here some of the lower pulmonary red flags. Of course, if we had a URI that was just worsening in susceptible people, so especially elderly patients or immunocompromised patients, patients with chronic lung disease, they get a URI, they're at much higher risk now of developing pneumonia or something like that. So maybe have a deeper cough. Now, yellow sputum is often thrown out there as an indicator of a more severe, maybe bacterial infection, and especially if the sputum is green, then people are like, well, that's definitely bacteria. Actually, studies have shown you can't tell from the sputum if it's viral or bacterial. So a lot of fairly benign viruses can actually create pretty yellow, even greenish looking sputum. And so sputum color alone is not adequate for that. From a more traditional angle, we would say more yellow-green might indicate what we call heat, and that would indicate a stronger cytokine response, especially with fever. If there's patients that are healthy, they get a cold and just doesn't go away after a couple of weeks, I might want to look deeper. Is there an underlying allergic pattern, chronic reflux, something like that going on? Any new onset difficulty breathing in a child 8 years or under, that really needs a full evaluation. Children are can really decompensate quickly, and they can go into respiratory distress. So that's something with pediatric health. There's a whole another level of kind of awareness we have to have around patients. And definitely with the respiratory disorders, this is one area where you have to be very careful and be sure they're getting the appropriate diagnosis and care. Severe asthma, and that would be at least two of the following. So rapid worsening breathlessness, greater than 30 respirations per minute or more if it's a child, heart rate over 100, so tachycardia, difficulty speaking due to the breathlessness, need to sit up, in order to breathe. And then central cyanosis is a very worrisome sign, and that's a pulse ox. You put the pulse ox meter on the finger. It's less than 85%. This is an emergency referral. And then, unfortunately, a lot of people can present with a panic attack. It seems like an asthma attack. And if they have asthma on top of panic disorder, or panic disorder on top of asthma, then it might be difficult to determine that. But measuring the pulse ox can be a usual way. Usually a pulse ox over 95% and above, we're not as worried, but when it starts to get below 95%, definitely down to high 80s, and by 85%, very concerned that the patient is not getting proper oxygenation. The increased heart rate and respirations are an indicator in asthma that there's inadequate air exchange, and so the body is trying to compensate for that. So that would be a red flag. Hemoptysis, vomiting or coughing up more than a teaspoon of blood. Blood stained sputum is actually not uncommon even in upper respiratory tract infections, so that's not a reason to panic. But anything more than a teaspoon could indicate worst case scenario lung cancer. It could be something like bronchiectasis we'll talk about, pulmonary TB, or a pulmonary embolism, and so forth. So that would be a potential red flag that needs further assessment. New onset chronic cough or deep chest pain in a smoker. That's obviously, we've talked about red flags before, but red flags such as unexplained weight loss. Patient is basically saying, I've lost 30 pounds in 6 weeks. I'm not trying to lose weight. I'm not on a diet or anything, and I'm still eating normally. That could be a potential red flag, especially in older patients, especially if they've been smoking, and if they have even things like night sweats, they cough up blood, or they have this new onset cough or chest pain, they need workup. So they need to get a chest x-ray. We currently don't do routine chest x-rays on people because it's a radiation exposure, so we need to be guided by the clinical presentation to order that. Unexplained hoarseness for more than 3 weeks. So hoarseness can have a lot of different things. So we can have chronically, polyps on the vocal cord, as I had mentioned. We can have vocal cord, inflammation in general. There can be herpes virus infection actually on the cords, but it can also be a compression of the recurrent laryngeal nerve, and that can be from esophageal, upper esophageal, or a lung cancer tumor. And so, especially if a patient's had a history of smoking or heavy alcohol use, this would be another urgent referral for imaging to see if there's a tumor there. Pneumonia, we'll go into that in depth, but this one is one you need to be very careful about because pneumonia can also decompensate very quickly, can be fatal. This is where you're having an infection, either viral or bacterial, in the alveoli, not in the airways. So alveoli is where you do your gas exchange. So if those little alveoli fill up with pus, which often happens in pneumonia, you're going to have very limited to no gas exchange in different portions of the lung where this is occurring. So this would typically present with cough and fever, a lot of malaise. Again, tachypnea, greater than 30 respirations per minute in an adult, heart rate over 110. Difficulty speaking due to breathlessness, need to sit up in order to breathe, and then again central cyanosis under 85%. All of these would be urgent referral, but pretty much unless you're a primary care physician and have access to the antibiotics and so forth that you can prescribe, pneumonia should be a referral at least to urgent care, where the person can get, if they're stable, they can get outpatient treatment, they can get just a round of antibiotics. But we'll talk about when we need to think about hospitalizing patients with pneumonia because, again, they can decompensate very quickly. Pleurisy also is something that needs a higher level of sort of assessment, and that would be localized chest pain with inspiration and expiration. Of course, we always want to rule out with chest pain. We'll go through all those differentials later, heart attack and things like that. But if there's fever and breathlessness and pleurisy, that might be another indicator of pneumonia. But this would probably need further assessment. Features of tuberculosis, TB, chronic productive cough, weight loss, night sweats, blood and sputum for more than 2 weeks. We are seeing a bit of a resurgence of TB, and especially in the homeless population. So that's a definite concern, and so that would be necessary to properly work up with the right testing. And then features of any pulmonary embolism, that'd be sudden onset chest pleurisy, breathlessness, cyanosis, collapse if the PE is large enough. Again, urgent referral. And then any features of pneumothorax, so severe breathlessness, possible pleurisy. So I adopted these from Claire Stevenson's book, Acupuncturist's Guide to Conventional Medicine. You might want to look at that for more detail. But this is kind of for lower respiratory disorders, some of the red flags we always want to keep in mind. Biomedically, the typical sort of approach to respiratory disorders is to first do complete history, and that would include history of present illness with past medical history, family medical history, social history, allergies, medications they're taking, including supplements, herbs, and so forth, and then a complete review of systems. Then we usually do a physical exam where we look at we do the respiratory exam where we look at the general appearance and vitals, look for any labored breathing, respiratory distress, look at their blood pressure, they're having a fever, look at the pulse rate. Again, over 110 usually indicates that there is severe respiratory effort being made the heart is really beating quickly to pump the blood to try to maintain some level of oxygenation for blood flowing through the lungs. And then respirations over 30, pulse oximetry under 85. So those would be some of the things that we're looking out for. And then an ear, nose, and throat exam. We usually do that for upper respiratory tract disorders. So we look in the ears, look at the eardrums, the outer ear, see if there's any redness, injection, any fluid behind the eardrums. Looking, of course, at the mouth and the throat, see if there's any redness, swollen tonsils, etc. And then palpating the lymph nodes in the neck, very important there as well, to see if there's any lymphadenopathy. And then cardiopulmonary exam would be part of that too, so doing a full lung exam and cardiac exam. And then any other relevant tests that might come out, like abdominal exam if that's indicated. Labs are going to vary for respiratory tract disorders, but typically for common colds, things, we don't do any labs. But if there's signs of more cyanosis, if we're worried about maybe a more extensive infection, we might do a CBC to look at the white blood cell counts, check your CMP for glucose, electrolytes, your liver kidney function, proteins. Rarely we need to do sometimes, and this will be more in the severe, maybe exacerbation of chronic bronchitis, person's really breathless, they get admitted to the hospital, they might do what's called an arterial blood gas from the radial artery. They actually draw and they look at the concentration of oxygen and carbon dioxide in the blood, and that's more accurate than the pulse ox. And then we can test for specific antibodies to various pathogens, again usually not indicated. For most of our respiratory tract conditions, including pneumonia, we don't go searching after the pathogen. That's going to have some applicability like in the ICU and hospital setting, nursing homes, but for community acquired pneumonia, what we get out in the general population and so forth, we don't really do that. And then sputum examination, again, not typical. That is done in TB, but there has to be special tests done. It can't be just a regular sputum test. And then imaging and other tests, we have our pulmonary function test. So I talked a bit about pulmonary function testing in the physiology section, looking at the different lung volumes, spirometry, and I'll go over that here in just a minute again. Looking at chest X-ray, doing a CT scan of the lungs, maybe radioisotope scanning. This can tell us basically what we can calculate what's called the ventilation to perfusion ratio. So how much air is getting into the lungs, and then how well is that tissue being perfused. And we should see about a 1-to-1 perfusion to ventilation rate, but that's going to change with different lung disorders, and that can be measured with the radioisotope scanning. Bronchoscopy would be putting a scope down into the bronchi, and that can be used for diagnosis, but also potentially treatment, pulling out foreign bodies, taking a biopsy, and so forth. The laryngoscope is going to be used to visualize the vocal cords, so that just stays up in the throat, and that is used by the ENT doc to kind of see if there's anything growing on the cords, any inflammation or damage there. And then we could do a lung tissue biopsy, often through the bronchoscope, but it can also be done outside the chest wall. So that's the general kind of tests and approaches biomedically to looking at different respiratory disorders. And as we go into each disorder, we'll look at which specific tests are used. So let me say a few more words about the lung physical exam. There are 4 basic aspects. So the first is inspection. So we're going to look at for most of our patients, we're going to look at the chest for symmetry, any sort of scoliosis or kyphosis of the spine. Kyphosis, of course, when you're bent forward, hunched over, like in severe osteoporosis. But that can happen. We see that often in emphysema. People really are using their accessory muscles to breathe. They get very thin, but you can really see their neck veins are actually their neck muscles are constantly being used to help them breathe and so forth. Looking for the chest muscle strength, if there's any atrophy, that can happen in different neuromuscular disorders. Size and shape of the chest, are they thin, are they normal, are they barrel-chested? Barrel chest is something, again, we see in emphysema. And then the ease of respiration, are they using any of those accessory muscles? So we make a note of all that. Then we inspect the fingers for clubbing, and that is a widening of the fingertips and loss of the angle of the nail. And this happens very common in chronic respiratory disorders like COPD, but also lung cancer. And so you see the angle disappears there. So this is something just to look for, especially if a patient comes in complaining of a chronic cough and so forth for maybe many years. Check for the clubbing. And that's interesting. We're not exactly sure what causes clubbing. We think it has to do with either hypoxia to the peripheral capillaries, causes a proliferation of the tissues. There's also an interesting theory that there are growth factors that the lung actually, if it's healthy, inactivate in the blood. So it's almost another deadening aspect of the lungs on the blood. And if those growth factors are not inactivated in lung disease, then they're going to cause proliferation in peripheral tissues. So that's another theory that's out there. So that is the clubbing. Then we're going to inspect the pharynx. We're going to look at the throat, check for sinus pain, maybe press on the sinuses, and then look in the ears usually, and then palpate the cervical lymph nodes. So that'd be more part of an ENT exam there. The palpation of the lungs themselves, you want to make sure your hands are warm. You put the hands on the sides of their chest. You're actually going to feel first the depth and excursion of the lungs. And you're going to look to see that the chest wall feels compliant. Is it stiff? Is it rigid? Or is it moving nicely with the breath? So you can see in the picture over here, you put the hands on the back, have them breathe, and you're checking for all those different features. You can also, if you suspect pneumonia, what happens in pneumonia is that a portion of the lung will become consolidated. What that means is the alveoli fill up with fluid, with pus. And so normally they're hollow, and you should have a nice sort of tympanic sound if you tap on the chest, for example. But if a person speaks or says something, it shouldn't reverberate or anything like that. But if you fill up those alveoli with fluid, it now carries sound, and you can actually feel vibration on the surface of the skin. So you can have the person say 99. In German, this was first developed by a German physician, and he used the word 99, but a lot of people don't say that, so we just say 99 here in the US. And you feel for the presence of what's called fremitus, and that's a soft vibratory feeling. So if you put your hand over the back, over portions of the lung, and if they have pneumonia consolidation in those areas, you have them say 99, you'll feel a vibration on the skin. So that's called tactile fremitus. So that's one little test we look for. The next step is to percuss, and that is to using your hands, you put one finger against the skin, and then you tap on it with your other finger. And you go over the different quadrants of the lung, and you should hear a nice sort of tympanic sound all throughout. So that's kind of drum-like. If it sounds dull, that usually means that there's consolidation there. So that would be dullness on percussion would be indicating more of a consolidation in that lung tissue. This was actually a very important way of diagnosing things like TB and whatnot, and where it's affected, which part of the lungs it was affecting before we had X-rays. So it's kind of these exams are still done. There's kind of the older generation of doctors are kind of lamenting that the younger generation aren't really using these exams because they're just getting the imaging and so forth. But I find clinically it can be very helpful. Auscultation's the last part here, and that's listening with the stethoscope. And we're going to listen on the back and on the front. So you're going to listen at all these positions in the blue. So usually we take the diaphragm of the stethoscope, place it here, starting between the spine and the scapula up here. And we have the patient breathe in, breathe out, do that over here, over here, over here, all the way down, making sure we get all the way down to the bases of the lungs here, and checking for any abnormal sounds I'll talk about here in a second. In terms of the front, we usually do that in combination with the cardiac exam, which we'll talk about later. But in green here is the sites you want to listen to the lungs. So right up here over the trachea, then on either side in the first rib intercostal space, then down here, and then down at the sides as well. So we can check the front as well. That's not always done typically, but that's really part of a standard lung exam to listen to those areas. What we're looking for are, for example, vesicular breath sounds or normal breath sounds. Those should be low-pitched without any gurgling or bubbling sounds. When we start hearing bronchial breath sounds, we hear this over the major bronchi. They're normally higher pitched. They have a tubular quality. So it's almost like a constricted tube, air rushing through it, and that usually means there's some phlegm or airway constriction in that bronchi. And then rhonchi would be coarse bubbling sounds, so that's going to be typical in bronchitis. So you're going to have a lot of phlegm in the bronchi, and so we hear rhonchi in those situations. Rales, which are the same thing as crackles, are fine little crackling sounds, and what they are actually the alveoli popping open as you breathe in. And if they've been filled with fluid or pus, as they pop open, you'll hear that. And so that's the rales. So we're always listening for rhonchi and rales. Rhonchi, again, would suggest there's mucus, phlegm, potential pus in your airways, and the rales or crackles would be in the alveoli. It kind of sounds like Velcro tearing. And then whispered pectroliloquy, is an accentuation of sound transmission. When you ask the patient to whisper, again, 99. So we already looked for tactile fremitus when they said 99. Now they're going to whisper it. And again, if you're going to hear an accentuation of that sound in areas of consolidation. So if you listen to the lung, you have the patient whisper 99 in each of those positions. If there's consolidation in one of those positions, it'll sound a lot louder in that area. Egophony is when you have the patient say A, and if you have an area of consolidation, it doesn't sound like A, it sounds like E. So it comes through, the tone is slightly shifted. And then we listen for wheezes. We might hear that in asthma, especially in the expiratory phase. And then what are called friction rubs. And that's when you breathe in and it almost sounds like sandpaper or something rubbing, grating. And that's really the viscera pleura rubbing against the parietal pleura. And that we hear in pleurisy. So that's a friction rub. So those are all the different kind of lung physical exams that we typically do. Again, for just a general exam with no respiratory concerns, we're not going to go through all those tests. But if a person comes in with what we suspect is a lower respiratory tract infection, we're going to want to document all of that. Now, there are a number of imaging studies that are done for pulmonary imaging. Probably the most useful, actually, least expensive, is the chest X-ray. Very common. We usually do what's called a posterior to anterior PA view and a lateral view. So the X-ray beam goes from the back to the front and then also from the side. And so that's usually for people, they have to stand up. If they're too sick to stand, we can do an A to P, but usually it's P to A. The denser the tissue, the whiter it is on X-ray. So bones are going to show up very white, but the soft tissue is going to be black. But we can look for areas. So here's a normal chest X-ray, just to kind of give you some landmarks. So here is, of course, the spine. Here are the ribs. You see on each side here is the outline of the thoracic cavity. And here's the diaphragm down here. And then you have down here the edges of the lungs, the margins of the lungs. So this is the base of the lungs down here. This is the silhouette of the heart. So it normally should occupy no more than 50% of this side of the lung. Now what you see in heart failure, we'll look at some pictures later of that, it's going to look like that. So the heart gets enormously large in there. You should normally see a little bit of, these are like little lymph nodes and whatnot. That's not overly enlarged, that's normal. And actually a lot of this is actually the airways, the little bronchi that are going down in there. Here's the clavicle, of course, and your sternum on there and so forth. Okay, so that's a normal chest x-ray. But if you look at a person with pneumonia, you see a couple things. Number one, you start to lose. So normally you should see this nice, clean margin at the base of the lungs. And notice how that's completely obliterated here. And we're seeing all this fogginess. That is the consolidation from the infection. Now, in this person, it's kind of hard to tell, but it looks like the heart is actually a bit enlarged here. So I can't tell if that's the outline here, if it's this one, but basically this could be a person with heart failure that has pneumonia as well. So that would be a useful tool for differentiating pneumonia amongst other pulmonary conditions. So we'll see that, we'll talk about that when we look at these different conditions in detail. A CT scan is going to be a lot more radiation, something like 200 chest x-rays, but it's going to create a three-dimensional image of the lungs, have much higher resolution, and so this is going to be used to detect different, like things like lung cancer, parenchymal lung diseases, and so forth. You can do a procedure called the pulmonary angiogram, where a radioactive dye is injected into the bloodstream, and a CT scan of the lung is obtained, and that shows you the blood vessels in the lungs, and that can be helpful for diagnosing a pulmonary embolism. That'd be that blood clot within a vessel in the lungs. In MRI, there's no x-rays, it's the magnetic field. It can be uncomfortable though, because patients are in that tube, you know, and the very loud sounds of the magnetic field banging are not always comfortable. Different contrast agents can be used to enhance the lung and so forth. We usually use this for different mediastinal diseases, areas of the hilum of the lung, which are not easy to differentiate with CT or X-ray, are better seen with MRI. And then we have our lung scans. I talked about the perfusion scanning. So the Q scan, this uses technetium-99. It's injected into the peripheral vein, and it's going to show us where the blood flow might be blocked in the lung. So that again could be useful for diagnosing pulmonary embolism. And then a ventilation scan is you inhale xenon 133. It's a gas, and the scan is obtained, and it can look for any areas of the lung where ventilation is blocked. So these are more specialized tests. You have to go to special centers that have that equipment. So these are not as commonly used, but those are possibilities, especially for more advanced lung diseases. You can probably use those more in hospital than outpatient. And then bronchoscopy is where a fiber optic scope is placed down the major and the minor bronchi. And this can, you can actually take a biopsy. You can do what's called bronchial washing, and then they suck up that substance and they collect the cells, and that allows for biopsy of any suspicious lesions and also allows for removal of foreign body. And then if you're only going as far as the larynx, that's the laryngoscopy. So these are some of the imaging techniques that are available for assessing lung disorders. Probably our most useful and non-invasive test for assessing respiratory disease are the pulmonary function tests. And this is going to, it's performed using special equipment. A lot of either primary care doctors or internists. Internists are medical doctors who have a little more intensive training than general practitioners in especially cardiology and pulmonology and so forth. They'll have these in their offices. We actually have one at the NUNM clinic. But the spirometry allows for assessment of lung volumes, can assess flow rates as well as diffusing capacity of the lungs. So spirometry basically is going to measure the amount and the speed of airflow that's exhaled per second. So we can see how quickly a person can exhale and how much they can actually inhale and exhale in total. This is very common, and we can get a little graph. It's not shown here, but maybe I'll show you some pictures later that will tell us different things about what the underlying lung conditions might be. So it's very helpful for assessing asthma, pulmonary fibrosis, cystic fibrosis, COPD, and so forth. For the important lung volumes would be total lung capacity. Remember, that is how much you can maximally inhale, exhale, plus the residual volume of the lungs. And the vital capacity, which is going to be how much you can maximally inhale and exhale. And then your functional reserve capacity, which is another measure there we looked at. So basically, those four are very useful to track different pulmonary conditions. There's another meter we use in the clinic just for like asthma assessment, and that's called a peak flow meter. Peak flow meters can be helpful for monitoring therapy. They're not good for diagnosing things like asthma, but they can be used for follow-up therapy. And that's where a person breathes out into this tube as quickly and as much as they can, and then we can see what their peak flow is. And then you can go online and actually look for peak flow charts for patients based on age and body size and so forth. And so that will tell you if they're in a normal range or if they're too low. It can also be helpful if you're treating asthma from visit to visit to see if there is actual improvement in their airflow. So FEV1 is a common spirometry measurement. It's forced expiratory volume in 1 second. This is highly reproducible in each individual. Really, this is governed by the condition of the trachea and the bronchi. So it's going to be looking more at the airways. A decreased FEV1 is going to indicate some degree of airway remodeling, so from mucus, inflammation, swelling, or scarring. It can also indicate a respiratory muscle weakness, like myasthenia gravis, which is an autoimmune disease where you create antibodies against the neuromuscular junction. It's going to affect your breathing muscles, and we're going to have a decreased FEV1. FVC, forced vital capacity, is total amount of air expired after maximal inhalation, and that's no time limit, just how much air can you get out, period. So the ratio of FEV1 to FVC is actually a very reproducible standard for people, and it actually compensates for variability in lung size, and it gives us a standardized value across the patient population. So that's a big one we look at here. Peak expiratory flow rate, again, this can be measured with the peak flow meter, and this is the maximum rate at which air can be exhaled from the lungs. So that would be from the peak flow, which might be helpful to have in your office. They're pretty inexpensive to get, and you might want to, if you work with a lot of asthma patients, maybe have one on hand. The spirometry is a bit more expensive, and that needs more specialized training. Most lung diseases fall into, these are chronic lung diseases, into either obstructive or restrictive defects. Remember, obstructive has to do with the airways. Restrictive has to do with the lung parenchyma itself, the elasticity and so forth. And we can use pulmonary function testing to differentiate. So an obstructive lung disease, that would be things like asthma, chronic bronchitis, emphysema, bronchiectasis. We're going to have a residual volume and total lung capacity is going to be slightly increased. The lungs are actually going to hyperinflate distal to the diseased airways, but the FEV1 is going to, in the peak flow, are going to be both decreased, and we're going to get a decreased FEV1 to vital capacity, or it should be actually FVC, forced vital capacity. So FEV1 to FVC. In restrictive lung diseases like pulmonary fibrosis, some of the lung parenchymal diseases like the interstitial diseases, we'll talk about like asbestos and silicosis and things, they're going to have a decreased FEV1 and FVC, but if you take their ratio, it's actually normal and actually a little bit increased. So the problem is not so much the air getting in from the airways, it's the lung compliance is disturbed. So we can use spirometry to sort of differentiate those different patterns. Okay, so that's a summary of the basic biomedical assessment and the different tools we use to evaluate pulmonary disease.